got a lifetime of knowledge.
Let me call Mimi.
How's your brain power? Have you had your coffee?
Good. We did have some. Can you hear the background noise?
Yes.
Okay, Stephen,
can.
we can't do this now. Not the
No.
time. You can't do anything now. I'm sorry, I told you.
Let's give a shout out to our earliest listeners and all the gals who have been giving us amazing feedback.
Yes.
Robin, Megan, Cass, Lizzie, Mia, Sammy, Sam
Sammy.
Swain, Chloe.
Hammy.
We
All of it.
truly have taken it to heart, and I think that we're really getting close to a proper, repeatable structure.
Yes.
So,
I love it.
yeah, I'm excited about it.
Okay.
To it.
Yes, let's do it. Should we do the
Okay.
intro?
Yes, let's try it.
Okay.
Great.
Let's do it. Welcome to Actual Experts. I'm Caitlin.
And I'm Lundie.
We don't have all the answers, but we're going to ask the questions.
Today, we are diving into postpartum depression with Dr. Sarah Oreck. A very important topic, I think one that is obviously not the happiest to talk about, but that I think affects more women than we even realize, and that a lot of women in our lives, and I'm sure more and more as we start to get pregnant ourselves, etc., will have to deal with. And I think even if you don't deal with it yourself on a personal level, it's good to know the signs and what to look out for and how to support someone in your life who is going through it.
Totally. I know.
yeah.
It's so crazy chatting to a few of my friends. They were like, this hits you fucking hard. Like one of my friends said she just had a baby a month ago and she was like, literally, you go into this dark place where every single thing that you've never solved in your trauma comes back all at once and your brain is like, must navigate all of these traumatic incidents of my life. Like your childhood trauma is on full display in the spotlight as soon as you
Yeah.
pop out that baby,
I've
which is
heard
so
it, I mean,
crazy.
it's just, I think, the most vulnerable state possible for a woman is those couple of weeks, couple of months after giving birth. And I think growing up, what we equated to postpartum depression was like intrusive thoughts and having feelings of wanting to harm your baby or wanting to harm yourself around your baby, which I think is a very real part of it. But I think it's so much more complicated than we even realize.
So much more. So much more. And I'm super excited that we're doing this, but also that people are talking about it more because it does feel like we were basically villainized to a degree for having postpartum for a really long time. And what you're saying is like, we're like, oh, postpartum equals you're going to murder your baby, shaken baby syndrome, all these things. I feel like there's like 10 CSI episodes on shaken baby syndrome with someone with postpartum. But now there's just so much more. And I'm excited to know what we can do and how we can help and how we can be there for our friends through this.
Okay, awesome. Yeah, let's get into some actual facts and figures, some actual numbers. One says that the CDC estimates that 1 in 8 women experience symptoms of postpartum depression, but other studies place it closer to 1 in 5. So 20% of women are facing this, and I don't think it's something that we acknowledge enough.
I'm curious to know also with that number, like what qualifies it, because everyone has a freaking hard time after they give birth. So like, what's the difference between postpartum versus just it's hard, you're sleep deprived and you don't know what to do? I'm really curious about that.
Exactly. That's something I'm really excited to get in with Dr. Oreck is what is classified as postpartum depression, what's just baby blues, which is maybe just the colloquial term for it. There's something called perinatal depression. There's different levels of it. To that point, actually, according to the Cleveland Clinic, 70 to 80% of new moms experience the baby blues. So what's the difference there? Unfortunate stat, the National Institute of Health states that suicide is the leading cause of maternal mortality in the first year of postpartum,
That's
which is
so
crazy.
sad.
Yeah. So realizing that, I think it just gets really dark. I think if you don't have the right tools or resources or support around you, then it can be hard to get out of. So it's on the rise for sure. It says that postpartum diagnosis has nearly doubled up from 9.5% in 2010. I think this is in the US to 19% in 2021. And the rates of diagnosed postpartum depression have climbed dramatically, revealing growing awareness and likely a growing burden. So I'm excited to get into with Dr. Oreck. Again, are these numbers rising because it's truly happening more, or is it just that and women are talking about it more? So the other interesting thing about Dr. Oreck is that she's actually one of the few reproductive psychiatrists out there. There's not
Oh,
many.
cool. It's a really hard topic, and all these things we go through and we talk about, and we've brought up menopause before and how that's not studied. I'm excited for us as women going into these next chapters that more and more people are studying this. And I feel so lucky to be at this stage in society where people are focusing on postpartum depression. And maybe it's not as many as we need, but there's this momentum going. So
Yeah.
I think as much as it's hard to hear these numbers, again, knowledge is power. And the more we know, the more we can understand and be empathetic, but also help the people around us. So I'm super excited about it.
Another stat here, according to Harvard Health, is that Black and Latina women are significantly less likely to be screened or treated for postpartum depression. Another thing that we should be more aware of, and I think increasing that awareness just generally, so that this is how we approach the topic around dinner table, conversations.
Again, I'm excited for this next chapter for us because people are talking about it, which is the important part. And then hopefully there will be change in the system. So very excited.
Exactly. So final kind of crazy stat to really frame this conversation before I introduce Dr. Oreck is that postpartum is the single biggest hormonal crash in human biology. And it is more intense than puberty, PMS, and menopause combined.
Oh my God.
During pregnancy, estrogen and progesterone skyrocket. And then once the placenta is delivered, those hormones plummet. And the drop is more intense than puberty, PMS, and menopause combined. And people wonder why women don't feel like themselves
That is so crazy.
after giving birth. And in the weeks and like truly months, let me look up how long does it take for hormones to level out?
My friend Kim was saying that when she spoke to her, both psychologist, but then physiotherapist, you have to remember it takes 9 months to grow a baby. It's going to be 9+ months for you to get back to normal. Like your body has been doing this for 9 months. Now you need to go back. And she was like, I did not prepare for 9 months post baby recovery. I thought I'd just snap right back. But
Right. And we're not even that's the physical that's not
Totally.
even get
Exactly.
into the pressure that it is to get like the pre-baby body quote unquote back, but like the mental and just
No.
feeling like yourself. I've heard so many women say it's the biggest identity crisis you've ever felt, and it's lonely because your partner, even with the best of partners, doesn't feel that. And so that's isolating. So it says hormones generally balance within 3 to 6 months after giving birth, but the timeline varies depending on factors like breastfeeding, which can prolong the process. So it's like the pressure that we put on ourselves to just
so crazy.
feel like ourselves and feel excited to have this new thing in our lives that has
Totally.
completely turned it upside down.
Totally.
And what a
That's crazy.
blessing, yes, of course, but come on. So that brings us then to today's actual expert, Dr. Sarah Oreck, who is a board-certified reproductive psychiatrist and co-founder of Mavida Health. Is a leading voice in women's and maternal mental health, and like I said, is one of the few specialists in reproductive psychiatry. She blends, and this is interesting, modern medical treatments with talk therapy and meditation to help women navigate the emotional challenges of motherhood. I love that. I want to get into that. And through her private practice and virtual clinic, she's making specialized care, therapy, and community more accessible for women everywhere. So very excited to get into it with her. I like her approach a lot, and we're so lucky to have her. So
Yay.
let's
I'm
bring
so
her
excited.
on. Please note that this pod is for educational purposes only. Nothing we say should be taken as financial, legal, or medical advice. Please do your own research, and when in doubt, ask an actual expert. Okay, well, thank you, for taking the time and for joining us. This has been a couple weeks in the making, months in the making almost. So very, very excited to have you on. Today, we're obviously tackling postpartum depression. Caitlin and I did record a little pre-episode intro, so we listed some kind of stats and facts.
What stats did you use out of curiosity in terms of the prevalence, for example?
Yeah, good question. I have the CDC estimates that 1 in 8 women experience symptoms of postpartum depression. Says other studies place it closer to 1 in 5. So
I mean, I
very
think it's probably
prevalent.
1 in 3. So yes.
Wow. Okay. Yeah. Good to know. I said 70 to 80% of new moms experience baby blues, according to the
Yes,
Cleveland
that's right.
Clinic.
Yeah.
So excited to get into the difference between those two. And I think the other kind of big one that was kind of crazy and grounding is that postpartum is the biggest hormonal drop or depletion in human
Ever.
ever.
Yes, exactly. Exactly.
Ever for all humans and
And it all
combined.
happens right in a day, which is just so different from adolescence and menopause.
Crazy, crazy, crazy. So yeah, excited to kind of get into what that all means. The last thing in terms of context is that the way that we like to do these between Caitlin and myself is that one of us does all the research for the episode and will kind of lead as the interviewer. And then the other one comes in blind as essentially our listener. So she hasn't done any of the research and she'll be interrupting us kind of throughout to say like,
I love
sorry,
that.
clarify that. What do you mean by that?
Great.
So
That's so smart. Yeah, that's really smart.
thanks. Amazing, amazing. But over to you, our actual expert. Thank you for joining us, Dr. Sarah Oreck. So excited to have you. Just to get into your background a little bit, I saw you said online that you first got into this field because your mom couldn't get the care that she needed. Tell us a little bit about that and how that got you here.
Great. I think that was one of the reasons I became a physician. I ended up landing in this particular niche for a variety of different reasons, which I'll discuss. But I was probably like 10, 11, 12. So those preteen years, which are, I don't know for you guys, like I remember them so clearly.
Yes.
I did such a huge change developmentally. And my mom was in her early 40s and she was hit with what we now know is perimenopause. And she was really young. The average age of menopause, that's when you stop having a period entirely, is 51 years old. And so we think the average age maybe is like mid 40s when you start to have perimenopausal symptoms. But how long was that now? I'm going to reveal my age, almost 30 years ago. That was just not something that physicians were talking about. And she basically went through 5, 10 physicians. Like, what is happening to me? I'm having night sweats. I'm having trouble with like brain fog. I'm having mood swings. You're too young for menopause. It's absolutely not that. Like the differential was like cancer and trying to rule out all these other things. And there was just really not a conversation around it. And I think my mom felt really isolated as being one of the first people kind of in her friend group or amongst people she knew that had these symptoms. I'm sure it was affecting her sex life and the way she saw herself as a woman. And so all of this in some ways really impacted me because certainly I felt like the mood shifts as a young child. And I think also kind of seeing that she just was so frustrated and not getting the care that she needed. Ultimately, after like maybe 5 years, so like maybe till she was like 45, she got the treatment that she needed and there was like a huge shift. But it was the first time that I had seen her like with depressive episodes, anxiety. It was really, really hard. And I think I didn't know it then, but that was my first experience of medical gaslighting. And I don't know if I would have said it in this way, but I think it made such a huge impression that I really wanted to be a doctor that listened to my patients.
I asked, what is medical gaslighting?
So gaslighting is such a popular term that's thrown out, but I think what ultimately I see, and now that I really specialize in women's mental health and seeing women basically all the time, is that you present a set of symptoms to a physician, and because it's not something that we learned in medical school, or it's not well described, because frankly, all of the research that we are handed in medical school is based on studies that were done on men.
Yeah.
And because those symptoms don't sort of coalesce into something that we know about, we say, oh, you just don't have that. That can't be. Those constellation of symptoms don't make sense. That's in your head. And I see that, I have to say, maybe like in 8 out of 10 of my patients. So yeah, this is exactly what it was. It was like, I'm having all of these symptoms, and you didn't have Dr. Google back then, but you did have like I'm having, brain fog, I'm having this, I'm having that. And all of these symptoms look like something, but you're just not the age that my textbook told me. Right. You have perimenopause or menopause, so you don't have that. Like there's the lack of flexibility of like, maybe there's something here that we still don't know about and you may have. Right. Maybe you're an expert in your own body. And instead of me telling, oh, you're depressed. I think that's the thing that she got the most. Oh, this is all anxiety. This is all mental health issues because you're just not the age that we typically see for perimenopause or menopause. And so that's still something that happens today. I see this in weight loss, frankly. You have women who have gone through years of every single diet, exercising. I do less in and out, and yet I'm still overweight. And they're, oh, you're lazy. Oh, you must be closet eating. Just less calories in. You know, and this
Right.
is where we see, I mean, another topic on its own, GLP-1s really revolutionized this for so many women who are finally like, I knew something was going on.
Right.
No textbook described it. I don't have the markers of insulin resistance per our labs, but clearly there's something different about my metabolism. And you can see this very clearly, the jokes about like, you know, you and your husband go on a weight loss journey and he stops
Totally.
drinking soda and loses 30 pounds. Meanwhile,
right.
you're like, I can't lose a pound over here. So
Right.
our bodies are so different from men, and yet that is what our foundational like Western medicine system is based on.
Right.
And I think
That's
that
scary and so isolating.
so isolating. And so it's interesting. I thought for a while I wanted to do OBGYN. And then I fell in love with psychiatry. And then I was lucky enough to go to Columbia University for residency where they combine these two. There was something called reproductive psychiatry and women's mental health. And
Very
they
cool.
really, and it's a field that's only existed for 30, 40 years, but it's really recognizing that female reproductive hormones have an insane and really intense impact on mental health that makes us very different from our male counterparts. And that there's
Right.
so many unique features to this, including the journey to parenthood, including perimenopause, but also every menstrual cycle. So because of our menstrual cycles, we were, you know, not allowed to be in so many studies. You rule out people who have a menstrual cycle, so
crazy.
you rule out, right, anyone with female reproductive hormones. So, you know, it's really an incredible field. I'm so lucky that it combined a lot of my loves. And I'm so thrilled to be at a time where we're starting to open up the conversations about these mood shifts and these hormonal shifts.
Yeah.
Certainly in the path to parenthood, but I've also started to see it in perimenopause. So I'm thrilled about that.
That's exactly what we were saying in the intro, is that we feel lucky to be doing this or to be approaching having children or families when it's being talked about. Because there were stats around how postpartum depression diagnosis had nearly doubled from 9.5% in 2010 to 19% in 2021, maybe even higher now in the US. And the question was, is that actually that the diagnosis is increasing, or is it just that women are finally talking about it more? And to your point, being believed more or being,
Yes.
you know, listened to
Yes.
more. And
It's probably a combination, right? Like, I
Mhm.
don't think it's one independent factor. It's a little bit like autism diagnoses. When you have medical providers who start to actually learn about this, are clued into it, you are going to get more diagnoses, right?
Right.
Before that you didn't. But I also think that there are so many stressors, especially in the United States for modern mothers, that
Sure.
probably make the rates go up, frankly.
Sure. Yeah, that makes sense. And we'll get into that. Another stat that we had read previously was that only 25% of OBGYNs have adequate training, quote unquote, in maternal mental health, according to the American College of Obstetricians and Gynecologists.
Yes.
So with you being one of the few specialists, and you noted that it's a very young field, in
And what's tough
reproductive
is that I'm a psychiatrist, right? Like, I'm not the frontline OBGYN. And
Right.
that is a big issue in medical school and in residency. And I have to tell you, the amount of time that's spent on this is a fraction. I mean, OBGYNs learn so much. There's actually been an argument that obstetricians and gynecologists should probably be two separate fields because it's like surgical skills and obstetrical skills. It's so much. So I feel for them in the sense of like, I don't know where you fit in this mental health kind of information and data, I'm seeing that more of it is happening. And it's like, it's hard to ignore because we're in a maternal mental health crisis in this country, frankly. So I think even if you want to ignore it, it's going to come at you in your OBGYN practice. So we're seeing it more. And yet I still find that there are a lot of blind spots and issues here in the diagnosis. I also think there's fear. A lot of people don't want to admit that they have these concerns because of what that may mean. And of course, that has there's racial bias, right? If I say this, is CPS going to be called? And certainly there's a lot of concerns there.
So why do you think then that is that there's such a stigma still around maternal mental health, both discussing it and treating it? You noted, obviously, studies aren't done on us, so that makes it difficult. But
we do have studies now in this field, but yes, generally and in medical kind of research and academia, it's limited.
So do you see it? I mean, at least we're having this conversation. People are talking about it more and more, but there's still such a stigma around it. Why do you think that is? Do you think we're moving in the right direction? Or
I think we were. I think we were. And there have been these kind of movements in America that are frankly anti-mental health, anti-psychiatry. And I think it's going to make irreparable damage. I mean, this is across all scientific communities. So I think it's hard not to talk about politics when it comes to this because our political circumstance is directly impacting science. I mean, even that this is called actual experts. It's almost like a dangerous podcast.
I know.
Right. Yeah,
I know.
That's true.
It's like controversial.
I would love you to just tell us a bit about that, Lundie, if that's okay to jump in there, because I think, to your point, it is so relevant what's happening in the world around us right now, and it will directly affect us, what's happening. And so if you're comfortable with it, I would love to hear what your position is.
If you've seen my Instagram, you know I'm comfortable with it.
Yes,
even despite what some people tell me to do. So I think what's hard is that there is this regression, I would say. Make America Great and Make America Healthy Again is really about bringing us back to this idealized world of the 1950s where women, frankly, didn't have control over their medical information. Where your
we couldn't even have
would have to consent to you having care. So it's idealized and it doesn't make any sense to me. Even going back 30 years, like to my mom's experience was horrific. Like going back to the 1950s, no thank you.
Totally.
So that is sort of the idealization that women have a place in the home and not anywhere else. To me also indicates they don't have a place in sort of medical information and medical research. And we know that as more female physicians joined the ranks of doctors, that we get better medical care. And yet that's something, right? I think this administration would love, and it's clear the messaging is like, go back home, stay home. Don't go out, don't have these careers. And frankly, it's in the numbers. The slashing of women's health research has been, incredible. And it's not just that. It's pediatric cancer research. It's things that I didn't think were controversial. It's all sort of going down the drain. And frankly, it seems to be, again, an idealized time that doesn't make that much sense in terms of what the progress was. I think it's also eroding trust in medical institutions like the CDC. And certainly, I think we're going to have a brain drain, which is a lot of our best researchers are going to be poached by other countries, fortunately, to continue their research as they should. But it's really incredibly devastating. And I think what's been interesting about that time is companies like Mavida Health that are private will have to, in some ways, kind of take on doing a lot of that research. And that's exactly what we're doing. We don't have personalized medicine or an understanding of Lundie, you come in, you have a baby, and you have postpartum depression, it's still kind of like, let's guess what medication might work for you. We have sort of some algorithms and some understanding, but we don't know exactly what would be the best treatment for you right off the bat. That's what we're trying to do at Mavida Health. But, it's a lot to take on, and to feel like these NIH, the CDC, these institutions are no longer going to provide that information that, as a physician, I, grew into this field relying on.
Yeah.
You mentioned that female research is being cut dramatically. Is medical research for women being cut more than medical research on men?
I think all research is being cut.
Yeah.
So I don't know if we know those numbers, but like women's research was already small enough.
Totally.
And it was finally getting a foothold, and then that's going to regress. But sadly, it's everything. It's things, again, that we didn't even think were controversial. To think that public health, that even how we make sure that your food isn't contaminated with E. coli or other bacteria is being rolled back, is just wild to me, especially with Make America Healthy Again. It's like it's an oxymoron. It just doesn't make any sense.
No, it's crazy. It's a crazy time. And to your point around your online platform, which has been growing, and as one of the voices really in maternal mental health, I feel like we've seen online a lot recently, a lot around women sharing the truth behind the struggles of motherhood. And I've also seen counter kind of viewpoints where people say, all we see is the struggles of motherhood. Motherhood is actually this beautiful thing. And so really we should be talking more about, and I think it's like the pendulum swings, because for the longest time, no one or no women were speaking about the struggles. And, and now it's maybe heavily siding on the side of struggles, and maybe we're not celebrating it quite as much. But, it's like every woman should just be able to, say what they need to say.
I disagree, but it's a little bit of like the what is it, ballerina farm? What's the
ballerina farm.
It's like the trad wife thing. It's a little bit of the she's a trad wife, but she's making bank off of you looking at all these videos.
Totally.
Okay.
Totally.
Fine. She's an entrepreneur. She's not a trad wife. She's an entrepreneur.
Yeah, joke's on us. Joke's on us.
Exactly. So in some ways, it's like we've had so many years, and there's still so many people that highlight the beauty, right, and the challenges. I think it's the issue with Americans not being able to hold two truths at once. Motherhood can be really painful, and it can be really hard, especially because systemically, this government does not support mothers.
Right.
As much as we want to say that they're trying to protect, pregnancy that's 3 weeks along, you are not supporting mothers by not having a paid federal leave policy. You are not supporting mothers by having unaffordable childcare. You're not supporting mothers by having school shootings that are rampant and happen more than the days of the year. So I think all of those things are not supporting mothers, and I think it's okay for people to highlight that motherhood comes with some suffering. But I also see many images of, again, you can have the two things at once, and the experience can actually be for one person, it can be really hard and it can be really beautiful. But I think it's being reflected, frankly, in parents and people who don't want to have children, right? In that there are some people that are deciding to not have children because of all of these forces, and I think that's okay. For people to see the reality. It is not sort of all rainbows and butterflies, and you need to make the decision for yourself of what is sort of right for you.
Yeah.
And I also love the idea that our partners are seeing this too more.
Yeah.
I think that is a big
that's
thing
part
too.
of the issue too.
Yeah, and that's a big thing. I've chatted about it with my husband. Sometimes I'm like, oh my God, did you hear that so-and-so had a baby and they had the worst postpartum they could possibly have? And it's almost like I'm projecting this onto him to prep him for what could come. And so for me, this increase in narrative and conversation and social media presence and all of it is helpful for me to be able to share that with my partner too, to better prep them for what's to come.
And it's not all doomsday, but it's like if your partner shared more of the mental load, we may not get into all of these cases of postpartum depression. If you could coalesce sort of that village, that family to come and help, to help you do some of those sleepless nights, we may not get people that have so many cases of postpartum depression. So I actually think that talking about it is really, really helpful.
Okay, that's interesting because a lot of what at least I was reading, or maybe my misconceptions or assumptions, was that postpartum depression maybe is predisposed,
There's
maybe
some
is,
genetic predisposition. Yeah. Yeah.
or is possibly entirely hormonal, and so your partner actually has no say and know-how in taking that off your plate because what
Absolutely
happens
not.
internally is internally. So I want to get into that, and that maybe is a good kind of segue into this episode, which we title so eloquently, "What the fuck is postpartum depression?" That's how we title all of our episodes.
I love
Can
that.
you walk us through what is postpartum depression actually? What causes it in our bodies? What's going on in our bodies chemically, hormonally? What is it?
So we're still trying to figure that out, but I'll tell you what we think is going on is that there's hormone changes, obviously, that your hormones have gone up the most they have in your entire life during the third trimester of pregnancy. Your estrogen, your progesterone, those are some that you may have heard of, are sort of like at an all-time high. And then you deliver your baby in the placenta, and it has this dramatic drop, like you mentioned, you never see at any other time of your life. And it's really within like 48 hours, which is a much shorter time frame than your adolescent sort of increase in hormones or your menopausal sort of or perimenopausal change in hormones. So it is a really rapid withdrawal that can destabilize mood for a lot of people. What's interesting is that there's also these like neurotransmitters that are involved. People forget that estrogen has a really big effect on serotonin, but there's also dopamine, the GABA system, and we think that together these hormone sort of changes kind of start to make some derangements in these neurotransmitter systems. And then we think there might be actually be an inflammatory process to all of this that we still don't totally understand or know about. But what can increase your risk? Family disposition. So if your mom had postpartum depression, if you've had a history of depression yourself in your life, if you had an IVF pregnancy or really struggled getting pregnant, if you had previous loss, a traumatic birth. So there's a lot of risk factors. If you're having issues with your partner or financial stressors, the list just goes on there. But what's really interesting is that we have to talk about the things that mitigate it. So you may have all the risk factors. Your mom had postpartum depression. You had depression in the past. You had a baby via IVF. It may not make this experience like not go away or completely change the outcome. But what we do know is that if you have support, if your partner is with you, if you have someone who is going to help you through this journey, like a little help with the baby, if you have a toddler to have help with that, to get some sleep. Sleep is a huge mitigating factor, by the way. If you can get some sleep, at least like 4 to 6 hours, we can prevent some of this depression from becoming really severe, for example. So I think it's important to think like, yes, there are huge risk factors, but there's ways to mitigate that. If you're on the right medication, if you're in psychotherapy. So what we get a lot at Mavida Health, for example, is someone who had a horrific first kind of postpartum experience. Then they come back to us for subsequent pregnancies, and it's worlds apart.
Wow.
Worlds apart. Because I just want to be clear, there are ways to sort of prevent or mitigate some of this fallout. So I think that's really important, and maybe that's not the nuance people see with like, oh my God, postpartum is just horrible and I'm going to have postpartum depression. That's not it at all. And frankly, postpartum anxiety is actually more frequent, even though we talk about postpartum depression a lot more. And so that's also sort of something that people are sort of at risk for.
Super interesting. My misconception was that it's something that either is predisposed or is just going to happen one way or the other, mentally, internally, hormonally, and that there's very little that can be done about it. So I want to get into all those mitigating factors. And then also on the flip side, if you have an incredible partner and you are getting pretty good sleep and you have your family around and your village, and even still you're having these thoughts or even still you're feeling these
And that can
things.
still happen, but medication is there, psychotherapy is there, group therapy is there, and we know that all of those can improve this outcome.
Can I just ask a clarification there is you said postpartum anxiety. What's the difference between postpartum depression and postpartum anxiety?
They come together a lot of the time, but anxiety is really, we're going to see more worries. We're going to
Okay.
see things like intrusive thoughts, which you may or may not have heard of. This is like these really freaky thoughts, like I'm holding my baby. I still get this one. My baby's 17 months. I'm walking down the stairs and I imagine that I just let her roll out of my arms and she rolls down the stairs. And a lot of
Scary.
people are like, oh my God, am I homicidal? Am I a terrible mom? And it's actually, no, your alarm system of your brain has gotten bigger during pregnancy. That's called the amygdala. And you're actually looking out for every single kind of potential risk to your baby. And so what do I do when I have my baby and I have those thoughts? I hold her a little bit, tighter. I look at where I'm stepping to make sure that I'm not going to fall. And so in some ways, it's this biological mechanism to keep our babies safe during a really kind of scary time where they have very little. Our infants, unlike other mammals, do very little. They should probably still be incubating, but our bodies can't kind of hold them in because they get so big. And so it's a really interesting phenomenon, but it can be incredibly disturbing.
Yeah.
All of us have had intrusive thoughts. You probably imagined a person like naked that you're like, I never want to see that person. Like, it's so weird. But when you're younger, like you're like, oh, that's gross. Okay, I'm moving on with my life. But when you're in this really vulnerable time because of the hormonal changes, you're like, wait, does this mean I'm like a bad mom? What's going on here? You also see a lot of health anxiety. So I have a hard time going to sleep because I'm afraid my baby's going to stop breathing.
I've heard
All
that a
of these
lot.
types of things. Yes, or going to the pediatrician constantly because, oh, the baby has a little rash. What could it be? What's going on? Is he breathing? Is he not? And so all of this kind of together. So in some ways, it's similar to what we see in generalized anxiety, but sometimes you can see panic. So people having panic attacks during this time. You can see all sorts of things. Kind of, it can get to the point where it's like OCD-like, so obsessive compulsive disorder, where there's just like, some of these people won't let anyone else take care of their baby. And you can imagine what ends up happening there. You have a mom that starts to become burned out. And then what you see is like then depressive symptoms ultimately come as well. And so these two are often kind of together.
Okay.
So anxiety sometimes comes first and then it could lead to postpartum depression.
Yes. And imagine if you're like in this anxious cycle, you're just like, oh my God, how am I ever going to get any sleep? Because I'm the only, I have to watch my baby sleep basically because I'm afraid that they're going to have SIDS. They're going to stop breathing. So it's really difficult. They often come together, but what we see is the prevalence of postpartum anxiety is actually higher. We see more people with those symptoms, especially first-time mothers where this is like all new and it's all kind of scary. People that that start to have these symptoms in pregnancy. That's really important about both of these diagnoses, that we often talk about it in the postpartum, but about a third of these cases actually start during pregnancy.
Interesting.
Wow.
Interesting. Okay. Yeah, I've not heard that.
Yes.
Super interesting. Caitlin and I were talking about how growing up, postpartum depression was usually, at least for me, my perception of it was intrusive thoughts. And it was women who were then villainized for having thoughts of throwing their baby across the room while it's crying.
Yeah.
And was saying there's so many, what's the show?
I was like, I feel like I watched so many
CSI
episodes. There was like shaken baby syndrome, and this mother was villainized for going crazy after giving birth. But it's postpartum depression, or to your point, which I've just learned now, these intrusive thoughts.
Right, and that's quite. And I want to be very clear with postpartum depression and anxiety. And with depression, sometimes you have thoughts of wanting to harm yourself, maybe thoughts of wanting to harm your baby. With anxiety, what you have is really like overly conscientious. It's not, and I want to clarify because these CSI cases may have kind of, they're not medical. Hopefully there's someone that has medical expertise, but who knows? Where I think there's a lot of conflation between postpartum psychosis and postpartum depression. And so when we see these cases of infanticide, those typically are postpartum psychosis. Completely different diagnoses, may have some depressive symptoms, but these people are disconnected from reality. They often think that there is some kind of, like an example is, oh, my baby is, the antichrist and is, if I don't kind of do something about this, the whole world is going to die.
Sure.
These are not kind of the people that do this.
Typical.
Right. This is not typical postpartum depression, but I have so many patients that come to me and are like, does that mean that I'm going to do one of these horrific situations? And that is not the case. Postpartum psychosis is a different diagnosis. I have diagnosed it, I would say, probably 4 times in my career, maybe 5 in my career. It doesn't happen as often. It's about 1 in to 2 in every 1,000 births. But again, we get a lot of conflation here between
that makes sense.
postpartum
So if I'm
depression and
coming
anxiety.
into Mavida Health, for example, I'm a new mom, and I come to you with, I could list the symptoms, but I'm more interested to hear your take on what really would you say is the difference between baby blues, where you're like, you're good, you're just having a tough time, you're a new mom, keeping on,
Yes.
versus postpartum depression versus postpartum psychosis. And I also read about perinatal depression as well.
That's
So
in
what are-
pregnancy.
Oh, okay. Interesting. Okay. So that's one of the key difference there. Perinatal is during pregnancy. So baby
Yes.
blues versus postpartum depression, you really just defined the postpartum
Let's
psychosis.
start there. Yeah. So
Yeah.
baby blues is something that happens in 70, almost 8, we think maybe even up to 85% of people who give birth. And what it describes is this mood lability that happens. It's like that typical, I'm weeping one moment and then I'm so happy the next, and I have no idea what's going on with my emotions. We think this happens because of all of those hormone shifts. And it's like it's this like vacillation between like excitement and sadness and fear, and it can start to look like postpartum depression. But what we really think about baby blues is it happens in the first 2 weeks after giving birth. It peaks at about 5 days after delivery, and it looks different in the sense of like there's hopefulness in it. Versus when we start to see postpartum depression. Postpartum depression we really think about is if that persists over 2 weeks. It doesn't necessarily have to happen right after delivery. For many women, it happens months into the postpartum, or sometimes when they start weaning breastfeeding, it can be another kind of change in hormones, and we see it then. But what we really see is that baby blues goes away after the 2 weeks. We see that people are like, oh my God, I'm not sleeping now, but I will when my baby's a little bit older. With postpartum depression, we start to see hopelessness. I don't know if this is ever going to get better. I don't think I'm the right mom for my baby. And so the flavor of it like starts to feel very different. But what, the technical definition is that those symptoms should be there for more than 2 weeks for postpartum depression. So if your baby blues sort of continues into week 3 and week 4, then we're probably kind of running into an issue.
So first signs, that's really helpful to understand that benchmark of like, okay, around the 2-week mark, if things aren't starting to look up, maybe kind of just keep an eye on things yourself, and maybe, voice that to a partner, your community, your family, your friends.
But in terms of what we do with Mavida Health, which was the other part of your question, is that even if it's just baby blues, there's also this other thing that's happening, which is called matrescence. Like adolescence, your whole persona is changing.
Yeah.
You are, you're losing parts of who you were as the single kind of independent person in the world. And you're gaining a lot, but it's so complicated in terms of the identity shifts that regardless of whether it's baby blues, and maybe it's not major postpartum depression or like a major mood episode, we still think it's worth you having some kind of care, some place where you can, you may not need medications, but having therapy to help you in this transition is invaluable.
Yeah, that's incredible. And we spoke about in your bio that you blend your medical treatments with talk therapy and meditation, which I love. I'm really into the woo-woo. Do you find that you must believe that is kind of like the right combination? Yeah. That's true.
It's not woo-woo at all. Absolutely. I think because, again, we have so little resources. You have in sort of the healthcare system in general. I mean, it's crazy because we spend so much per capita on each person in our healthcare system. But what we find is like people have, mild to moderate depression or anxiety, and their OBGYN is putting them on an SSRI. I want to be clear. an SSRI works well for these symptoms. But for mild to moderate anxiety and depression, we know that therapy is the way to start. But because there's like no resources in terms of therapy, people don't get that evidence-based care. And so we really believe in blending those two. I think mindfulness and being present and connected to your body is, again, a gift that we can kind of gift ourselves and our children if we teach them early enough. Also think group therapy, couples therapy. People don't even talk about this, but sometimes the whole conflict is like, oh my God, now we have all of these tasks to do. We have a baby and we haven't even explored how that's changed our relationship. And often that can sometimes be the unlock, and that's all you kind of need. So I think there's so much space for the preventative care. And if it were up to me, like everyone would have couples counseling during pregnancy or even before trying to conceive to kind of get on the same page.
So even before then women get to potential perinatal depression or postpartum depression, anxiety, in the preparation for birth and all that comes with it, what would you tell a patient at Mavida Health if they come and they're interested in learning more about matrescence? What's the word?
Matrescence, like adolescence, yeah.
So interesting. Yeah. What should women know about that, and what can they speak to their partners about or their community about?
I think it's so important to kind of understand that as you have this baby, like you're also going to transform. And there's like the bouncing back culture of like, when am I going to just be back to myself? You never are, because your body will forever be changed. There's, your baby leaves DNA in your body. Like, it's really fascinating. You'll never be the same. Your mind is, we think that the brain changes that happen during pregnancy last 2 to 6 years from some neuroimaging that we've started to do.
Wow.
And so really
women are having babies like a year, 2 years, and you're pregnant for, 7 years. You're like just being thrown for a loop. You're never going back to any.
You're never
any
going
sense
back,
of
but like
normalcy.
in some ways, it's like there's so much growth and there's so much change, and honoring that and kind of understanding yourself and this new version of yourself. I mean, everything from your appearance to your kind of sexual desire or sexual interest. Like, there's so many things that change your identity in work, for example. Your values, your goals kind of rearrange. And so I think therapy is such a great gift for all of those things, and to just try to kind of have a place where you can voice some of the things that are happening, get an understanding more of like, well, what's going on here? Oh, this is what's happening. And so I think, just like I wish every adolescent had more sort of a safe space to go and talk about, oh my God, my body's changing and my skin's different and my hair's changing. But again, this is a conversation we can start to have with our community, with our friends. What changed for you? Just really, I think, more into that. Again, this is a way to have sort of preventative structures around postpartum depression, because so often I just hear, I've been at this alone. Everything's different from my hair to the size of my feet. And like, I'm just thrown for a loop. And again, if we can start to have more conversation, more openness about it, I think we'd all be in a better place.
Yeah. If we just set the expectation that sense of normalcy is probably not going to return, and that these changes are to be expected, at the very least, it takes the pressure off to that point of the bounce back mentality.
And that you're gonna gain so much, but it's just challenging. You also asked about postpartum psychosis. And so the reason I probably don't see it as much is because I don't work in an inpatient psychiatric hospital and I don't work in an emergency room. But when we think someone has postpartum psychosis, that is an emergency. You need to go to the ER. If your friend or your loved one starts to kind of say things that are just not making sense, if they are really not who they are, what's so interesting is sometimes you have this fluctuation in consciousness. You have people that are kind of like there and then don't seem like they're there, or kind of like out of it. You need to go to the ER. And typically how we treat this is psychiatric hospitalization, and then after that we can actually see those patients. And we've seen those patients at Mavida Health very successfully after they've gone to an inpatient unit and been stabilized. And it's a long journey, but what's really important to discuss is that if you treat postpartum psychosis, it's not like other severe mental illnesses like schizophrenia that just stays. These people go back to who they were. So they have this period of psychosis, and then after months, they stabilize, they are back to who they are, they're connected with their babies, and they can have a really phenomenal rest of their postpartum experience, but it's tough.
That's great to hear. I know I have some personal relationships with different types of personality disorders, but knowing with postpartum psychosis, it's great to hear that there is that possibility of, and you can and should get back to where you were before.
Yes, and can anyone experience postpartum psychosis? Can someone who has never experienced any level of depression or anxiety or mental health issues or illnesses, so a perfectly quote unquote normal woman can start experiencing this and then be treated and then bounce back? But it's extremely serious, and it means there's a high risk of harm to the baby or the mother, it sounds like.
Absolutely. But yes, anyone can experience it.
Scary.
That's why I think people are so fascinated by it and also scared by it.
And to that point, when it comes to intrusive thoughts, which it sounds like can come with any level of this depression, anxiety, perinatal, postpartum, what would you say women should do if they start to experience them? It sounds like you have yourself. It sounds like it's actually much more normal than we expect. And so what would you suggest a woman do if she's walking down the stairs and has those thoughts?
This is hard because I used to work in an ER, and I remember a woman who had come in with very clear intrusive thoughts, and she was really worried about them. And my colleagues were about to, admit her to a psychiatric hospital. Wow. And I intervened of like, this is not a psychiatric hospitalization, guys. Luckily, I went out because I am very persistent. But it is something that can be misinterpreted even by medical staff.
Right.
So this is what's challenging. I would say talk to your partner. And the thing to be really clear on is I'm horrified by this. I don't want to act on it, but this is what I'm experiencing, which is really different. And so this is something that we actually differentiate with psychosis versus anxiety, is one is ego dystonic and one is egocentric. So one is like, I would never do that. Like, that is so horrifying to me. And the other one is like, of course I have to do that or else everyone on the planet dies. Very different frames of mind.
Big difference.
So how can your part? So if I went to my partner Steven and said, I'm having these thoughts, I don't know why I'm having them, I don't want to do this, but it's really scary. How should Steven, my husband, handle that? Like, what's the best way for them? I would
wish that like everyone had be having these conversations about here's what intrusive thoughts are even before your pregnancy or postpartum. So you're like, oh honey, we talked about this. This is anxiety. Let's get you some good care, or this is my ideal with like everyone would start a relationship with someone like Mavida Health, and you don't have to like come in every week because you're fine, but you have them just in case things, aren't going well. And we have some people that are very kind of conscientious and maybe see us once during their pregnancy and they're like, I'm good. But they want to have us on call just in case things go south in the postpartum. And they're like, oh my God, this is happening. What can I do? And we have a lot of strategies in terms of therapy that can help with those thoughts. Also, if you start to understand them, sometimes I'm just like, this is your amygdala and it increased. That alarm system is bigger because guess what? You need to hear your baby crying at night. When everyone else is dead asleep, you're the one that hears the baby crying. This is parts of the brain that change where you're like, some moms are like, oh, my baby's hungry. And you're like, but the baby's just crying. No, like, that's a hungry cry. Like, I know this. And you're like, it sounds the same to me. But it's this really interesting change that happens to us. And sometimes people just like knowing that it's universal, that they're not alone in having these thoughts is enough to kind of help them.
Yeah. Right. But the hard thing is not everyone will be fortunate enough to have a therapist on call for them. And that is just unfortunately the reality of the system that we live in, the medical system we have. So with that in mind, how would someone in that moment or their partner, how do they manage that or navigate it if they are just the two of them or alone, or they don't have that
I think
resource?
the first thing is naming it,
Okay.
right? Trying to understand what's happening. Hey, I think this is what I heard this thing, and I think it might be an intrusive thought, and here's what I know about it. And sometimes just naming this big bad feeling, or sometimes you just saying this thing out loud can be enough to kind of let some of that power of it go away. This is what we talk a lot about in trauma. You know, when it's just like running in our head like a loop, it's really hard. But with the right kind of circumstance and the right trusting environment, if we can just say that out loud, it stops having so much power over us. I really
Sure.
think that's some of the key with intrusive thoughts. When it's just playing in your mind and you're like this homicidal mother who's going to be on the cover of the Daily Post, like that's really scary. But
Totally.
when you say it out loud and you're like, but I actually don't want to do this, and you have that sort of reflected back to you, it can be really life changing. But I think that
Helpful.
just yeah, it's a lot of like everyone has to get more psychologically minded.
Right. And would you say then, I mean, it sounds like maybe in that immediate moment, if you have your partner with you or a family member or friend, is that like a maybe hand the baby off,
Yes.
name it, have that conversation in that moment, get a little more sleep tonight, come back to this
Yes.
tomorrow?
I mean, those are great interventions because we know anxiety increases, intrusive thoughts increase with more kind of a fragmented sleep. So if you can get at least 6 hours of sleep, I trust me, like by the next day, you're going to be like, oh yeah, I don't really want to throw my baby out the window. Like that's insane.
Yeah.
I'm just really freaking tired.
Right.
And so I do think those are lovely interventions. And I think ultimately, to tell your doctor, hey, I'm having these thoughts. I do not want to act on them. Something I would say explicitly. I do not want to act on them. I heard that they're a part of anxiety. What can we do here? Can you refer me
Right.
to anyone?
Right. So therapy, it sounds like sleep, certainly get fresh
If it's
air.
extreme
What?
enough, yeah. Oh, I love nature, kind of going out, walking, movement, all of those things can be so
Sunshine.
helpful.
Yeah.
Support, having more people, the village help you with your baby, getting the nutrition that you need. So many new moms are hyper focused on breastfeeding or formula or what's the best way to feed. And they're not even, and they're like eating like packaged food or like a granola bar. Like
Like
your
ever, yeah, like
nutrition
the bits of their
matters.
toddlers
Exactly.
breakfast in
Yeah.
between
Yes.
feeds. Yeah, yeah,
And it's
totally.
like, no, your nutrition matters and it actually impacts your mental health. Like, that's going to help you. Good movement is some kind of exercise if you can. Taking out the baby for a walk in sunshine, your feet in grass around nature. We know nature
Right.
does so many great things for your mental health, but most importantly, sleep does.
Yeah.
That's like the best medicine. That's the top of my prescription pad is sleep. But if things are still really severe and you've kind of worked on all of these things, you're in therapy, all of it, SSRIs are a really fantastic option. They don't
And
What's an
have
what's
to
an
be
SSRI?
SSRI?
That's a selective serotonin reuptake inhibitor. So that is one of our frontline antidepressant, anti-anxiety medications that, of course, you may have heard about RFK Jr.'s kind of saying that they might be the cause of mass shootings. That is absolutely not evidence-based. Countries like Iceland and Scandinavia actually have the most SSRI use per capita. We think it's because it gets so dark there and that there's a
Yeah.
seasonal aspect of that. But that would mean that they would have the highest rates of mass shootings,
Totally.
and they absolutely don't.
It's almost
So
as if
that's
they're not
just
correlated at all.
right, exactly. It's almost as if they're not correlated. So selective serotonin reuptake inhibitors are sort of like that front line that we use for postpartum depression and anxiety. And those are phenomenal medications that, again, if all of these lifestyle changes, if the therapy doesn't work, then that's the way to go. But I have to say this, if you're having thoughts of not wanting to be alive, you've got to get into care right away. And a medication may have to be part of that treatment plan very early on.
Understood. That's important. And so it sounds like then in postpartum, even through breastfeeding, SSRIs are safe. So it's safe
Yes.
across the board. And for women who are predisposed to depression or anxiety, can they stay on their SSRIs through pregnancy, birth, and postpartum? Wow,
Absolutely. And so all
amazing.
of the experts in this field um, uh, have looked at all of the data. There are millions now of women that we've seen, and again, Scandinavian countries, because they have a really good data set, because they have a national health system. And we have seen that there are no increased risk of congenital defects. We follow kids up to 18 years old without any significant issues or differences. What I do have to say is if you have a history of mental health issues, there is a genetic predisposition your kids will have to those issues.
Sure.
But that it kind of flies in the face of an FDA panel that RFK Jr. assembled with a bunch of anti-medication experts who tried to say that this wasn't safe during pregnancy not so long ago. And
Yeah.
it's really a disgrace and a disservice because it's cherry picking studies that are meant to kind of incite fear versus actually understanding that there's risks to untreated mental health issues during pregnancy. And those are
Sure.
not talked enough about. So there's an increased risk of preterm delivery, of a C-section delivery, of not taking care of yourself during that pregnancy. And those can have very real impacts. And we've seen those have impacts, neurobehavioral issues in children, like the list goes on. And so that's another kind of issue. I also have to say that there is a phenomenal medication that has recently been on the market for postpartum depression specifically that's called
Interesting.
zuranolone, and it works through a hormonal kind of channel, and it's a really interesting medication that you only have to take for 2 weeks. And for
Wow.
women with
Wow.
severe postpartum depression, it is an absolute game changer.
Wow. Was it developed by women? I would love to know the research and
I
development
actually
behind
don't
that.
think
Sounds like a
so. I
miracle
think
drug.
that the intention was for it to be for all of major depressive disorder, but it happened to work really well for postpartum depression. And we think it's because it's a neurosteroid and there's some
Wow.
sort of hormonal underpinnings that may actually reflect what's happening with postpartum depression. So
Wow.
that I just love that that's kind of a tool in our toolbox because
Absolutely.
we had so little generally.
You did touch on Scandinavia being key market for a lot of research. As we well know, Scandinavia is a somewhat homogenous and
Yes.
largely white population. So I
Yep.
wanted to get into what we spoke about earlier with minority women being treated less and oftentimes being more
At
exposed to
risk.
postpartum.
Yeah.
Yeah, thank you. At risk as at postpartum depression. Tell us a little bit about that and what we can do about it.
Yeah. No, 100%. I think where we're getting a lot of the research, is a homogenous population, and it's one with, a safety net. It's one that provides like universal child care. It's one that provides a very generous federal leave for mom and dad.
Yeah,
So
right.
it's a very different population. And so we are kind of picking up scraps. And I don't think that they necessarily map on to the circumstances that many mothers have in this country. And so that's a little bit of the challenge. Even, this is really interesting, the questionnaires that are used to
Right.
ask, like, so typically your OBGYN or a pediatrician will ask you a list of questions and you have to like tick off whether you have some of these symptoms or not. And that's like the first screener for postpartum depression. One of the screeners was made in Edinburgh, and that's a predominantly like white place in the UK. We've adapted the
Mhm.
language to sound more American, but we have seen studies that demonstrate that it does not pick up the postpartum depression kind of symptoms in Black and Latino women
Wow.
for a variety of different reasons. So even the language, even the questionnaires are for a white population. And so
Wow.
there's so much there, but there's also the concern that many Black and Latino women are more at risk of being, of child protective services being called. I mean,
Right.
this is like,
So
this
scary.
is happening rampantly everywhere. So
Right.
it's a really tough situation, especially because this population in general has more risk factors, and yet we're not kind of diagnosing it as much in these women, and we're not presenting them with great options because,
Right.
frankly, we see more Black women die from childbirth, and the infant mortality rate is higher. I mean, there's so much here around medical bias. And this
Right.
is why it's such a disgrace when we think about our administration eliminating diversity and inclusion as if those
Yeah.
are bad things. But we have had a history of not treating women is one, but then Black women and Latino women. And so I
Massively
wish I could be
important.
more hopeful. I wish
Yeah,
I could be more
I hear you.
hopeful, but I just think the maternal sort of mortality rate, I think, in this country is going to increase. Not to mention restrictive abortion policies.
Right.
If you are
Right.
having an ectopic pregnancy and they let you die in some states before they'll intervene, I mean, like, it's just, and
Yeah.
certainly forcing anyone to have a child is a setup for postpartum depression.
Absolutely. Yeah, exactly. Odds are stacked against us, but such an important part of the conversation. So thank you. I appreciate the context there. You are, however, despite most of the feelings being hopelessness around what's
Yes.
going on in the US at the moment, you are working at this with Mavida Health. So tell us a little bit
Yes.
about Mavida Health, what you guys do there, and how women can find you there.
Yes, I was in private practice for a long time. I work with big health systems, and I just saw that there wasn't great solutions for anyone. So that's when I decided to start Mavida Health with my co-founder Emma Sugarman, who's an expert in like telehealth and building telehealth platforms. And we came together about 3 years ago, I think. We launched Mavida in September of 2023. And we've been at it. What the goal was to really do what I was doing in my private practice, but at scale. And so we train all of our therapists and our prescribers basically in like the school of what I did. So everyone is handed that knowledge and they become specialized in this maternal mental health space. And now we're extending into perimenopause. So it's going to treat more people. And we are doing this in network with most commercial insurance. We are currently
Amazing.
in California, New York, New Jersey, and Texas. And for people who haven't utilized mental health resources, you may not know this, but it's very hard to get high quality in network care. Has a long history actually with Medicaid. But for a long time, the thinking specialties, your primary care doctor, your psychiatrist, your neurologist don't get paid as much as your intervention physicians. This is why surgery is reimbursed really well. But for a long time, mental health didn't even have parity with other sort of procedures. And so you have this phenomenon of most therapists and very good psychiatrists being out of network. So that means that they don't take your insurance, that you have to pay cash, and then maybe you can get some reimbursement. That doesn't work for people. It's too expensive. It just doesn't make that much sense. And so what we really wanted was a high quality service that you could get through Cigna, Aetna, Blue Cross Blue Shield, and United Healthcare now. And so that has been a real game changer. And we're not at Medicaid yet, but that certainly is something I'm very, very interested in. But that's even more challenging.
Amazing.
That's amazing.
So yeah,
So people
congratulations.
who are on these specific services can look, and they're in these states that you're active in, or
Yes.
health insurance,
Yes.
and look for you.
Absolutely. We also have out-of-network care that's frankly lower sort of cost than most metropolitan areas. And we
Okay.
provide individual therapy, group therapy, couples therapy, as well as that really highly nuanced prescribing, all the way from, trying to conceive. So people who are going through IVF, we have even some people who are freezing their eggs. And may have some sensitivity to hormones or want to talk about this huge endeavor that they're going through, all the way through the postpartum. And again, we're starting to see perimenopause, and you can get in as quickly as 2 days, which is also something that's
Wow.
unheard of. Most mental health providers, it takes months to get into.
Right.
And we're online at mavidahealth.com. You can sign up there and also check out our Instagram, which is at Mavida Health, as well as mine, which is at Sarah Oreck MD. And you can learn some tips about how to make this time a little bit easier.
We love it. Honestly, I've been following since we got connected, and
great.
I've already learned so much. And yeah, so we'll make sure that there's links in bios once this finally gets posted. We'll send lots of people your way.
I have a quick celebrity jump in question, aka celebrity is my husband, Steven. So I was on a walk with him this morning, and I said we were having this conversation. We were walking our dog, Fred. And I asked him, like, as a partner, and we are planning to have kids relatively soon, what questions do you have? And his was, what should he not do as a partner that is there while I potentially am experiencing prenatal, postpartum, anxiety, all these different things that are going to be flooding my brain and my hormones? What should he do and not do?
Well, I'm going to throw you for a loop now, and this is like a whole other episode. About
Yeah.
1 in 10 dads actually get postpartum depression.
I had no idea.
Wow, that's so true. To be fair, I mean, yes, our audience is women. We're talking to the women, but that's an important part of the puzzle. You're a partnership.
They also have brain changes. They may not be as much as yours. And this is really interesting because we see this even like in gay dads. One partner may have kind of more brain changes than the other, but they still have brain changes. Adoptive parents have brain changes.
Totally.
You know, if you use a surrogate, there's a brain change. And so what's really important is, you know, there's this, unfortunately, it's what can he do? And he has to be the one that sort of, but I also want to back up a little bit and say he needs some checking in on too. This is why this nuclear family structure of just the two parents and the kids, that doesn't work for anyone. It's like for raising kids, it's truly the multi-generational. That's not accessible to many of us who maybe have moved away from our parents or our family. This is where like we need kind of more friends to check up on us or to have these sort of like cohorts. I mean, Europe is such an interesting model. We were there at a kids hotel, at a family hotel, which is like a couple weeks ago, which is a whole different conversation. But there's this communal kind of parenting where you get together with friends and the kids just run around and everyone is parenting each other's children. More of that versus this really isolationist, like mom and dad just doesn't work, because dad can also have postpartum depression symptoms. But your symptoms are going to sort of mitigate that. And so sometimes, and not that this is, it's like it's all on the women, but if when there's postpartum depression in the mom, there's a higher risk of postpartum depression in the dad. And so it's a little bit like if you have a little space, check in on him too. How are you doing?
Totally.
How are you supporting?
Great.
And frankly, he's also going to have a huge identity shift. It may not be as big as yours, but it's like now he has to like take care of someone and provide. And what's so hard, and again, a whole other topic, and I'd be happy to come back, is how we treat men and their mental health. They're meant to be stoic. They're meant to like just take it. You know, it's just like we want softness. We want, you know, I want my boys, and I have 2 boys, and I sort of tell them a lot of like, it's okay to cry.
Totally.
And the instinct sometimes of people around them is like, okay, stop crying and this. And like, no, cry.
Yeah,
have
toughen
these
up.
Emotions. Yeah, toughen up. And I think we really have to flip the script. But in the same way, I think that's often the script that's used for postpartum dads.
Yeah.
We want to be careful with that.
Yeah, it's so interesting you say that too, because I remember chatting to a few of my guy friends as they were becoming fathers, and they said there's so many apps out there for moms to watch the baby grow, and this is what's happening in your system and your brain and all these things that are going through. And there's nothing for dads because there's nothing for them. They're like, oh, my wife is screaming and crying on the floor. I don't know what to do. And there's no resource or either way, or this is how I'm feeling. Yeah.
And we don't like at Mavida Health, we welcome dads. But we see that they come in through their partners, through their wives.
Yeah, sure.
So often they're like, they do couples therapy and they're like, actually, you know, this is okay. Maybe I'll do individual therapy.
Yeah, it's kind of nice to have some support.
But I think we really need to soften how we see dads as well.
Yeah.
Sure.
Yeah.
In conclusion for this episode, we're hoping that everyone listening to this, whether they're either experiencing this themselves personally or not, what is something that you wish every woman knew about postpartum depression? What should people walk away knowing?
I think it's really important to think about how often it happens so that it's universal. You're not alone if you're struggling, but you don't have to struggle. There are ways to help. There are ways for you to feel better today. And I think that's really important. Like, I love the universalization, but I often am afraid of, like, does this normalize this? And people are like, I'm just going to have to, like, sit here and suffer through this. And my answer is always no. There are resources out there. The Mavida Health app, we have a, like, non-clinical version. So you can be on there and you can get all of our evidence-based videos, articles, and you don't have to be a member. So even if you're outside of our states, and it's a completely free. So go on there, kind of check out those resources for moms and dads. And that can be like a first place to start to get some kind of help.
Support. Amazing. Thank you so much,
Thank
Dr.
you.
Oreck, for joining us.
I
This has
have
been
loved
great.
this.
Oh,
Yeah, no,
have you
I've
loved it?
loved
I thought
this.
you had another
It's been
question.
great. I'm like taking all these notes. It's been so interesting.
Yeah, we've learned
You
a lot.
two are awesome. I love this like tag teaming.
6
Well,
weeks or so.
congratulations on doing this. Thank you both so much.
Welcome to the Debrief, where we discuss things we needed a little more clarity on.
Yay! Should we talk about yay postpartum depression?
Woohoo! I just finished watching the interview with Sarah or Dr. Oreck, I should say, and she's just like exceptional. We had
I'm
such a
obsessed
great
with her.
chat with her even after recording stopped, and she just, I think, had such a fresh perspective. And Mavida Health, I'm going to send everyone I know to Mavida Health. Like, what
I
an
know.
incredible resource, and I learned a lot. So should we get into takeaways?
Yes.
A couple things that just kind of stuck out to me. The first is that the politics of it all. I kind of want to touch on how this was really the first episode of our first 5 that politics have really like shown through. And Caitlin and I spoke about it after the recording, where we were like, you know, is this something we want to touch on? And I think it's just an important reminder that like none of this exists in a vacuum. And especially in the US right now, women's health is particularly impacted by politics, but really everywhere in the world.
Totally. And it made me think a lot yesterday. I was thinking about it, and her point about how the name of our podcast, Actual Experts, is in itself a little bit controversial, because there's so many people out there that are claiming a lot of different facts and information and reasons to do one thing or another without a degree in the topic or experience in the topic. And it's kind of, for me, it feels like this is actually such a strong and important time to have access to this information from people who have been vetted or just have experience in the topic at hand. And it made me realize that there is so much noise out there, which makes it so much harder for us as women to figure out what's the right thing to do for us. And everyone will make their own decision, but just really thinking about, who am I learning from, and how did they learn what they know, and where did that information come from, I think is so important for us to think about always.
Totally. Yeah, agreed.
Yeah.
And so hopefully this becomes a resource where people can trust that we've done our due diligence, that these experts are truly experts, you know, have 10, 15, 20 years plus experience in these fields. So I just wanted to touch on how I think, like, we can't pretend like everything that's going on globally and in the US particularly, which impacts the rest of the world, is not happening when we touch on these subjects. But when it comes to the actual topic, postpartum depression, I learned so much.
Me too.
I didn't know a whole lot about it going into it, but just some things that I wrote down. I think it's interesting that 1/3 of postpartum depression and anxiety cases start during pregnancy, which is, the word for that is perinatal depression or anxiety. Hearing that that's super normal and prevalent. So if you start noticing that while pregnant, it's a normal thing, but naming that and identifying that, super important.
I loved her topic about naming it. Like, just being able to put a title to it and a name to it, I think brings you down a level and grounds you a little bit to say, hey, this is not me losing my mind. This is a symptom of what I'm going through right now. And I thought there's a lot of power in that.
Totally. Agreed. And to that point, I think intrusive thoughts.
Yes.
The fact that that intrusive thoughts are actually, she said, a biological mechanism to keep our babies safe, because our brains are literally expanding to the point of absorbing so much more information than we're used to hear them crying or know when they're hungry. So that if you in your head are thinking like, my baby might go over the banister while I'm holding, it's like it's just interesting that that's where those thoughts come from. It's because our brains as mothers have expanded so much that like the world becomes scarier. It's crazy.
Totally. I mean, that our brains change. That's wild. And also the
Amazing.
brains of fathers, adoptive parents, gay parents across it. That is wild to me. It really shows
Wild.
you that we, at the end of the day, are these like crazy animals that change as we evolve throughout our lives. It just like all of it blows my mind. Again,
Totally.
science blows my mind. Every time we have a science related episode, I'm like, this is wild. Save the
That was
scientists.
crazy. And to literally hashtag save the scientists. Another super interesting discrepancy that I think is great for everyone to know is that the difference between baby blues and postpartum depression really looks like the time that you're experiencing those like hardships. So she said that baby blues peaks at about 5 days to 2 weeks after birth. And then anything after 2 weeks from birth, you're possibly looking at a longer term postpartum anxiety and depression. So good to know that the first 2 weeks are just going to be a fucking mess, a shit show, no matter what. And so just going into birth kind of knowing that, and then also keeping an eye on yourself or your partner, anything after 2 weeks, if those are really. And she said that also key difference is like a sense of hopefulness or hopelessness. So
Yes.
knowing like in the back of your mind, like, yeah, this is really hard, but I have help, or but there's a light at the end of the tunnel, or but my baby will sleep again at some point, versus none of that is really a key differentiator. So it's good to know.
So one thing is that 1 in 10 dads experience postpartum depression, and that is crazy. 10% of the population.
Significant.
That's significant. So
Yeah, significant.
check in with your partner. I mean, Steven was listening to some of it and he's like, God, women have it hard. And I was like, yeah, we do.
Yeah, like what a fucking ride. I mean, and also, I mean, talking to your partner, that was another thing that Dr. Oreck
Yes.
said, is talking to your partner before
Yes.
even pregnancy, and certainly before postpartum, to say all of these things are very real possibilities. Send them this episode. Make them listen to this episode. Get them prepared.
Totally. Okay. I
Yeah,
can go into mine.
for it. Yeah.
Okay, so she did say at one point some of the things that could potentially affect your predisposition to postpartum depression is different types of traumas, really hectic births. She also said IVF, and so I just wanted to be clear on what that means, because I think it could be a difficult thing to think about. Okay, if I do IVF, it means I'm more susceptible to postpartum depression. I looked it up. There isn't a direct correlation between IVF and postpartum depression. What it is, and this makes sense to everything she was saying, is that if getting pregnant already was really difficult, you're already in a delicate mental state that could then make you a little bit more susceptible to some of the harder feelings that come post-birth. So it's more about the variables that surround you through IVF, is what these studies are saying.
Sure.
That could potentially open you up to more postpartum depression. So I just wanted to be clear on that. 1 + 1 does not equal that, but it's the variables around you that could potentially cause postpartum depression. So I think that was also one. What I really liked also was she said 4 to 6 hours of sleep is like a magic pill to a degree.
Yeah.
That
She
can
said
really help
sleep
you.
is at the top of my prescription pad. She was like,
Yeah.
it can turn, she said, like the most scary thoughts to manageable thoughts through just sleeping. So sleep is key. And to that point, actually, of what you were saying earlier about like putting your mask on first with your partner, I've always, not a mother yet, we'll see how I feel when Luke may be sleeping next to me at the hospital right after I've given birth. But I've always read that like mothers want to kill their husbands, like if they're getting any sleep, like immediately after having babies, because they're like, I'm not getting any fucking sleep. Why should you get any fucking sleep? But in my head, I'm kind of like, wouldn't well, the mother's probably not going to get any sleep anyway. We're the ones doing most of the feedings, whatever, specifically with breastfeeding. But it's like one of you needs to have a functioning brain, hopefully.
Yeah.
So like, in my mind, I'm like, go sleep in a separate room. At least you get some of the sleep so that you know what I mean? Like sharing that kind of burden.
I hear what you're saying. I think as long as they're helping during the day so that you
Totally.
can take the naps
Exactly.
that you need to take.
Exactly. They
As
take the
opposed
morning shifts instead of the nights.
Exactly.
Yeah.
Exactly.
I mean, I already know Luke could sleep through a bomb going off, so that he will not be waking. I can already say with confidence with the baby,
Yeah.
but he's a morning person. So
Well,
I
that's
will
good.
say,
That's
get
true.
this child out of the house. Honestly, and every mother listening to this is probably like, just you fucking wait.
I
You
know.
have
They're
you have
literally
no
like, shut
idea.
the fuck
Yeah.
up.
They're like, yeah, you guys have no idea what you're talking about. It's true.
Exactly. Yeah, I think, I mean, you covered a lot of the stuff that I was thinking of too. Big win for me was also what we spoke about, speaking with your partners. And I think that's just such a common theme throughout everything we've heard, from merging finances with your partners to prenups to egg free. Like, all of it is just communication. Just seems to be such a
Yeah.
consistent theme. Who would have thunk it?
Communication. I know.
Who
Someone
would have
says
thunk it? Well, honestly, I'm obsessed with Sarah.
I
I
know.
want her to be my psychiatrist. She was so great. And I just feel like meeting women like this makes you realize that there are people in your corner and who are fighting the good fight, putting their name out there. And she said there's lots of people who tell her she shouldn't be voicing her opinion and how she feels so strongly about women's rights and access to health and mental health support. And it's just so great to hear that there's people out there standing up for us because we deserve it.
100%. And hopefully she'll be back for part 2.
Part
So
2.
stay
I
tuned.
can't wait. I can't.
But we'll see you next week.
Okay. Knowledge is power. Let's fucking go.